had a small office here in California. And as it stands, we have a tremendous block of business in that space. And I won't necessarily go through all of it at the moment around how we do it, but what I would say is if you have a opportunity that has a Japanese firm in the States, but has a parent company overseas in Japan or Korea, China, Taiwan, one of those countries, we have an interesting solution that I'd be happy to speak to you about offline, with Dave and Jennifer and his team. But basically, what we've been doing, or what we've been trying to do here with Shepler Fear, is we've got two facets to our business. It's obviously group employee benefits, so there's the medical piece, and then there's the ancillary lines. In California, we are in the large group space, 101 plus. So, and it's basically all firms. They don't necessarily, I get asked questions sometimes if they need to be Japanese or, Asian owned, and the answer is no. We will look at all accounts, all prospects over 100 lives for our solution, so on the medical side. So relative to our solution, our product is sort of a PPO-based type product. We don't have a managed care product per se, but in addition to our PPO product, we have what I call an EPO-like product, where it's virtually network only. And as I go through this, you'll see that part of why we have a lot of partners at Nippon Life, not being a huge carrier. So one of our partners, we have partners on the, with respect to our network. And the primary network that we use typically is called Aetna Signature Administrators, ASA. I am told that the ASA network, thank you, Dave. I'm told that the ASA network is very much like their largest, most robust network, which is their OAMC, I believe. So our network is solid, and our product is pretty solid as well. On the EPO side, or the sort of the lower cost option side, I said it was EPO-like because as you start to see quotes from us, you'll notice that there is an out-of-network component. And the reason there's an out-of-network component is that we don't own the network, right? So as a result of that, we have to have an out-of-network component. But when you see it, the product itself, the out-of-network piece, is so scaled back that nobody would ever want to go out-of-network for their services. So I believe the deductible out-of-network starts at $20,000. So if that doesn't say stay inside the network, I don't know what does. So we've been using our standard PPO product with this sort of low-cost option called the value plan, in tandem to quote sort of HMO PPO business when we look at opportunities. I can tell you that as a result of how well our business has been running the last few years, we've been very competitive in the large group space, or large group market. And I would say typically on the medical side, we're going to be very competitive within the, say, 100 to 250 area, 225, 250 area. And part of it is a result of our underlying business on the from our Japanese and Asian partners. It runs quite well. And so as a result of that, in the last few years when we've had MLR, we've always paid back a rebate, and sometimes it's been quite significant. So as a result of our underlying business, we are now much more aggressive in the large group space. I'm sorry, I thought I heard somebody ask a question. No, okay. So having said that, our solution with the PPO, the EPO, I can tell you that up here in the Sacramento area, Southern California, Orange County, We've got an account or two in the Central Valley. We have a very interesting solution that I think, given the right scenario, is going to be very interesting to you and your client. Now, what I can tell you is that the biggest hurdle you will have with Nippon Life and working with us is not necessarily our product and our service. It's really more our name, because it's if many of you have not heard of Nippon Life as a group employee benefit provider, it's a virtual guarantee that your client's not heard of us. So at the time of the pre-sale, we do provide Dave and his team, and you can certainly reach out to me as well, but we do provide some background around our financials, our ratings, and these sorts of things to give the client the comfort level they would need in order to move their business, or at least give us serious consideration when we provide a proposal. Now, relative to our medical business, as I said, we do have many partners, like we do on the networks. We also have an admin partner, and our admin partner is CoreSource. CoreSource is kind of our claims payer, eligibility, all those sorts of things, and they are housed in Des Moines, Iowa. For many years prior to healthcare reform, our partner was Principal Financial Group, but in 2010, when they made a decision to basically get out of the medical business, we had to look for a new partner, and we found CoreSource, and they're basically in the same town. Well, not basically, they are in the same town. So the folks that were working for us at PFG at the time literally got up from their desks, went across town, and sat down at desks at CoreSource. I believe it's most, if not everybody, came over at that point. So there's been some significant consistency there, which does help. So, to kind of just go back a moment, we have an admin partner, CoreSource. We typically use the ASA network, the Aetna network, but to be sure, and just so everybody's clear, we, Nippon Life, are on the risk, and we're doing the underwriting. And I think a little differently than most carriers, we do underwrite every case. Our underwriters look at it, so it sometimes takes a little bit of time. Not too bad, but based on workloads, and of course, this time of year, it's going to be quite busy. So, but we do have our underwriters review and provide us with quotes and rates on every aspect of our medical business.
Warren, would that, just a quick question, would that include groups just in California or also outside of California that you handle?
Yeah, I mean, if something were to come to you, Dave, I would be the primary contact for it, but I want you to, it's just so everybody on the phone is aware of it, we're not totally national in scope, meaning while we can cover people throughout the country, we're not licensed to write business out of many states here in the U.S. So California is probably our best opportunity. We are also in Texas, but I would very much suggest that we not review any accounts in Texas these days, because we're not all that competitive, and it wouldn't be a good use of anybody's time, I don't believe. We're also in New York, New Jersey, Pennsylvania, Michigan, Indiana, Illinois, and I can get you the rest of them. We're in the South. I believe we're in Georgia. But really, the focus of the organization and where we are in California is going to be to give us the best opportunity to write new business on the medical side.
So if it's a California-based group and they have employees in other states, that's not going to be an issue.
No.
If it's a domicile in another state, we need to check with you first to see if you're approved in that state.
Right, and I would tell you that we're probably in about 17 to 20 states total. Okay. But the other states that we're in, I know I can speak with a pretty high level of confidence that the quotes that we provide, I think they'll be competitive, but they may not always be the lowest. I think here in California, most quotes that we provide, depending upon the demographics and that sort of thing, we're going to be competitive.
Okay.
I think the biggest thing that folks have used us for new brokers that may not have been familiar with us in the past, is that given the nature of our business these days and what's happening in our industry, consolidation is happening all around us, and there are fewer and fewer carriers to go to. Now, the good news with a firm like a Shepler Fair, they have many different types of carriers that they represent. They represent Starmark and some others that we also I would equate ourselves to. So if you work with Dave and his team, you will be able to show your client something that's a little bit different than the kind of the same old when it comes to the Blues or UHC or Cigna or Aetna or one of those carriers. So being unique, I think, is part of the selling points to your customer base. Some of the other things that might be a selling point to your customer base are as follows. We have a bit of an old school service model when it comes to account management. So in my office, which by the way is down in Los Angeles, I have 3 service team members that are assigned to your client and as a point of contact. So for any high-level issues, any service-related matters, whether it be a claim or billing or anything like that, you will always have somebody to reach out to in my office. And, candidly, this is a very big part of what we try to do to differentiate ourselves. I hear varying degrees of what other carriers might be doing in the marketplace, and it kind of sometimes it depends on if it's the renewals coming up. You might hear more from the account manager at that point. But for us, the service model is quite important and is really going to be, we think, one of the main reasons that a client would want to come to us. Because on a 125 life case, it's a little bit unusual these days for a carrier to provide a kind of a HR level or a customer level contact for any service items. And certainly you can work through us on that directly, but obviously you also have your partner here at Shepler Fair to help you with those things too. But for you and your client and Shepler Fair, we have somebody that would be a point of reference around any service items for the client. The other thing that's also important is that we some of the brochure that is up here does mention self-funding, but I can tell you we don't do a lot of that. What I was getting to is that the majority of what we quote and provide is a fully insured product. We've been very competitive, and I suspect it will be like that for some time. But at the renewal, provided that the client has over 100 employees, not members, but over 100 employees enrolled in our plan, the client will get a full workup from us in terms of claims, premium, trending, pooling points, the whole 9 yards. I very much doubt that you would receive something like that from some of the bigger organizations on a fully insured case of 125 lives. Typically what we see is, from, and I don't mean to pick on them, but Anthem kind of provides a rate page with some options, and then they say, here's the increase, and they let you know if there are any large claims. We'll go much into more detail on that. And while sometimes in pre-sale scenarios it bothers me a little bit because we always provide that information, and the client or the other carriers can use that when they price their own business, when they look at ours. But the real value is that, for better or for worse, you will have some transparency, and your client will have some transparency around what's going on with the group as far as claims and these sorts of things. So therefore it's really a value to you, to your client, and to Shepler Fair, because unless the client is self-funded, it's going to be very unusual, I believe, that a client will get a renewal workup over 100 lives on a fully insured basis.
That's true. Yeah.
So that's one of the other value points to our plan.
Warren, let me ask you a couple of questions because I know we're going to be short on time here. So, talk to us about your Cdhp plans and HRAs and stuff.
Sure. Obviously, there's a lot more interest in these plans these days. It's a cost saving measure, a little bit more onus on the member. We can certainly can provide those, and we will, we can administrate them. I would say that we've seen, like I say, we've seen a lot of interest in that, whether it's introducing it to an HMO PPO group and making it sort of a third option, and whether contributions drive folks to that plan or not, that sort of materializes. But we can provide those products, and we can certainly provide one that has our value plan where there's a pretty large incentive for people to stay inside the network. So and it's becoming a little bit more prevalent. I just had some success with a law firm down in LA where they were already well versed in it, looked at ours, and are moving forward with our Cdhp plan.
That's good. Talk to me about working alongside of HMOs like Kaiser, because that comes up a lot.
Yeah, it does. So thank you. So one of the other things that we can do is we can offer our products alongside Kaiser. That said, though, we do need at least 40% participation on our plans. So Kaiser can have up to 60, and we need up to 40. Now, which is a little better than the marketplace. I think most carriers are 50-50, and they put in Kaiser alongside Anthem, and then over time the enrollment kind of erodes, and let more people end up on Kaiser than they do the Anthem product. And it's fine, and we're happy to do it, and we're happy to be, and we do have quite a few groups that are alongside Kaiser. That said, it's extremely important to understand that what we do see sometimes, and not a lot, but on occasion, where you've got a group that says 45% with UHC and 55% with Kaiser, and we quote make a quote, we provide it to Dave. Dave gives it to you. It sells. They conduct the enrollment, and then after the enrollment, it's now, instead of it being 45, 55, it's now 37 and 63. Well, in those situations where we're under 40% participation, we will require employee completed statements of health before we finalize the case.
Okay.
So that 40% is a little bit of a hard and fast, because even when I spoke to my underwriters about it, Warren, it's 40%, not 39.5, 40. So, and as you can imagine, it's not a great phone call to be having and with anybody. So I don't personally like making those calls, but on occasion I've had to make them, and as you can imagine, it can be a little bit of a mess at times.
But when we come to you with a quote, and let's suppose I've got a group of, just to use an arbitrary number, 200.
Sure.
And they currently have, say, 100 with Kaiser and 100 with United Healthcare, some other PPO product.
Right.
I mean, wouldn't we be right to identify who those folks are, where they're enrolled, and then you would quote on the PPO people, as opposed to the entire group? You base a quote on the 100 that are currently enrolled in the PPO?
Yeah, that's correct.
Okay. And then in the event that less than the 100 enrolled in the PPO, what you're saying is if it fell below 40%, say
right. So in that case, let's say it went to 75 people.
Okay.
We would probably want statements at that point. But if they had an enrollment change and it went from 100 to say 90 or 95, we'd be fine.
Okay. Okay. So the key thing is that when we submit a group to you, we need to have a pretty well broken out about where they're currently enrolled. Correct. At, so you have a better feel.
Correct. And and I will say very candidly, we do get a lot of requests for, well, they've got Kaiser in place, but they'd like to see it two ways. They want a full takeover, and they want you to see if you could just replace the Kaiser piece. And the second one is really more viable. I've never seen any client replace Kaiser fully once they're embedded.
Yeah.
So more often than not, you're going to get quote from us if the underwriter can do it that is alongside Kaiser.
Yeah.
So, yeah, I mean, I think that's important. The other thing I would say is that relative to the census data, we do need a member-level census, which is not unlike many other carriers these days. There's an underwriting tool that we use that will help us get a better picture of what we think might happen with the group. So we do need a member-level census.
So ages of the dependents.
Names, ages, dependents, and I can get
like we would for a small group quote now.
Yes.
Yeah. Okay.
But right, everything on dependents as well.
Okay.
Okay.
Yeah.
There are certain scenarios we do at times embrace the completed employee health statement prior to pricing. Groups coming out of trusts, which sometimes happen is that we get a group, say, from Western Growers that is out to bid.
Yeah.
At the end of the day, that's probably not going to be a great prospect. We won't say no, but we will ask for completed health statements up front because we just never get the information that we would like to have in those situations. So, groups coming out of trust or PEOs probably want health statements up front just so everybody's aware. So it may or may not be a good fit.
And do you have a health statement form that we would be using?
Yeah, we have a health statement form that I could send you a copy of, Dave, if you don't have it. But yeah, we would definitely do that.
Good. Well, I'm sorry. Was there a question from the outside there? Okay.
Okay. So as I said, we've got quite a few materials. Dave and his team have quite a bit of information on us, and I would encourage you to.
I'm going to show on the screen.
Okay.
If you don't mind, we have some collateral, and I apologize. I didn't get this put into a format that's easy to see, but this is their standard PPO product. They call it the Evolution PPO Value Plans, which again I kind of refer to them as an EPO product because it's got such a high deductible for out-of-network services. So it has, a pricing advantage that you would have over a PPO. Mm-hmm. And I think using that Aetna network really gives it a pretty broad base of providers.
Correct.
So these are the various deductible, coinsurance, and out-of-pocket limit combinations that you can have. They have some first dollar benefits and what have you. And you're using an RVRVS for non-network reimbursement. I find that's very interesting too.
Yes.
Oh, good point. Thank you. Sorry, Kathy. Sorry, guys, I was on the wrong screen there. I hope that helps. I told you I'm technically challenged. I apologize. And according to this, you have this. You have this approved in the states of California, Illinois, Indiana, yeah, Michigan, etc.
Right.
And it says 51 or more, but in California,
it's 100. Right.
Yeah. Okay.
That's right.
So that's the Evolution PPO plans, and as I recall in our prior meeting, you felt like those were the most competitively priced.
Yeah, definitely. They're definitely the most competitively priced.
And then here's your Cdhp plans, which of course we have a big interest in because we have so many clients that are looking at HRAs.
Right.
And again, these are, you call it the Evolution Cdhp plans.
Right, with the idea that the out-of-network benefits are going to be really geared toward driving people into the network.
Okay.
Okay.
And you can use those for both HRAs and HSAs.
Yes.
They're an HSA qualified plan.
Yes, they are.
Okay. And then let me just see here. Oh yeah, this was the special product for California. I see here with the high deductible.
Yes.
Correct. Network. Yeah.
Yep.
Okay. And then the last one that I recall was, let me see, this one here. We'll bring this over here. Yeah, this was the Evolution Value Series.
And that's just our standard PPO plan. And as you can see, the out-of-network deductible starts at $20,000.
Yeah. Okay. Yeah.
So
there you go.
it's pretty
Yeah. That's
pretty
a good idea.
pretty good incentive to stay in network. And
Yeah,
I would even say it is a good idea. And I would even say that for groups that have a PPO that are looking for a little bit of a price savings but still want the flexibility of a network, and it's been very successful, not only in those scenarios where the a PPO cutback type idea, but also, you know, on the HMO plans, we found it worked and it works quite well. And this is how we typically position it. Generally, what we'll try to do when we quote an HMO plan is we'll try to match up our value plan with the these three things on the HMO: the deductible, the copayment, office visit copayment, the prescription drug card cost copayment, and the out-of-pocket max, which is basically, I think, what most people on an HMO care about: their office visits, their prescriptions, and their total costs. Now, we still have these things called, you know, deductible and coinsurance in our value plan. So what do we do about those? Well, there's a couple ways we can go. And what we've had some success with recently is quoting a low coinsurance plan with a modest deductible, say 500 or 1,000. And the way you can position that is on the, at least on the deductible piece, is most HMO plans out there have some sort of inpatient copay of a 200 or 250 when somebody needs to make a hospital stay. So in those scenarios, you could say, well, that's sort of what the deductible would equate to. Anybody that has a large, has an overnight stay at a hospital, that deductible should be eaten pretty quickly.
Yes.
The other thing is that the coinsurance, if you have a low out-of-pocket max, say of 1,500 or so, the coinsurance at that point also almost becomes in network almost becomes virtually irrelevant, because what are you paying? You're paying the deductible, you're paying the RX and the office visit. If the maximum is 1,500, that it won't take that long to get to that maximum, and then everything's covered at 100% moving forward. So, and the price difference in these scenarios or the situation is really quite good. Now, oftentimes you might get some resistance from a HR person that says, "Well, you know, gosh, I can't give my HMO folks a deductible and coinsurance," and you know, and kind of express that, and that's fine. We can quote 100% in network with a zero deductible, and that's fine. But as you can imagine, then the employer's cost does go up. You know, there's a big price difference between a 100% zero deductible plan with versus a 60% 500 deductible plan.
Yeah, yeah.
So it does make a bit of difference there.
So will you allow for multiple plan offerings within a group?
Yes.
Like we could put in, say, a PPO.
Yes.
And then an HRA or Cdhp plan to be used, and have a dual choice.
Yeah, we
could
could
allow that to go alongside of an HMO as well.
Well, it'd have to be Kaiser, but yeah.
Yeah, that's what I'm saying.
I mean, yeah, we could do that, but.
Uh-oh.
Uh-oh.
Sounds like somebody put us on hold. Oh, I don't like that at all.
The fact that we're on hold, or the music?
The fact that somebody put us on hold and we're getting their music.
All right.
Oh boy. Let me see here. Okay. Well, I'm not sure what to do about that.
Muted. Unmuted.
Okay.
We'll,
I think we're going to conclude. All right. Anyway, we're going to sign off at this time, and I have recorded this, and we'll get back to you again. Take care.